diagnosis die from suicide, with approximately 20% of schizophrenia patients who have attempted suicide in their lifetimes. Some of these suicide attempts are in response to command hallucinations that motivate the individual to harm oneself or others. Suicide risk is also associated with depressive symptoms in a schizophrenia diagnosis, being unemployed and feeling hopeless with a period after a psychotic episode or after a discharge from hospital presenting with an increased risk for suicide. Let us look at the functional consequences of schizophrenia. A schizophrenia diagnosis is associated with a significant impairment in functioning, both on a social and occupational level. Attaining educational progress and maintaining a job is often impaired by avolition or other disorder symptoms, even when the cognitive skills are on par for the tasks to be completed. Most schizophrenia individuals are employed at a low level, and some do not marry and have families, whilst having limited social contacts outside of their nuclear families. In return, Bowie and Harvey in 2006 investigated cognitive deficits and functional outcomes for schizophrenia. The researchers highlight the question of why schizophrenia disorder patients are not functioning better when successful treatment of positive and negative symptoms for the disorder have been established to date. Their study determines that the answer lies in cognitive impairments for schizophrenia patients. Patients with schizophrenia generally have, as a group, lower intelligence quotient or IQ scores than the general population. Furthermore, these patients have deficits in attention, working memory, verbal fluency, verbal learning and memory, and executive functioning. The research highlights treatment specific to cognitive impairment if schizophrenia patients were to be more functional in society. Schizophrenia is mainly treated with antipsychotic medications that target and ease the symptoms of delusions and hallucinations. Antipsychotic medications work best for positive symptoms such as delusions and hallucinations, and may be less effective in targeting the negative symptoms of the disorder. Although antipsychotics are effective in treating delusions and hallucinations, they do present with many unpleasant side effects such as weight gain, sexual problems, drowsiness, dizziness, restlessness, nausea, and a condition called tardive dyskinesia. What is tardive dyskinesia? Tardive dyskinesia affects the muscles of the face, tongue, and neck, making these muscles move uncontrollably, with this condition being permanent. However, tardive dyskinesia often only occurs in some of the medications, and the patient's doctor will then try a different type of antipsychotic medication to check for its effectiveness and to avoid tardive dyskinesia. Let us move on with the treatment of schizophrenia. If other symptoms of mood may present, the physician treating the patient may prescribe a mood-stabilizing medication and or an antidepressant together with an antipsychotic. Oftentimes, schizophrenia patients receive psychotherapy or talk therapy to help them organize their lives and to assist them with understanding their disorder and to motivate them to keep on taking their medications. Although the disorder is not curable, psychotherapy plays a vital role in terms of supporting the patient with schizophrenia. Students, you have now received a lot of information on the key features of psychotic disorders and schizophrenia. Next, we'll be discussing schizophreniform and schizoaffective disorders. Let us continue our lesson. Students, before we move on to discuss schizophreniform disorder, let me first let you in on what's to come in our next lesson, Lesson 6 for your course diploma in psychology. The lesson's title is Trauma and Stressor-Related Disorders. These disorders are clustered together because the individual or patient has been exposed to a traumatic and or stressful event, with this exposure being listed explicitly as a diagnostic criterion. The specific disorders we will be discussing include disinhibited social engagement disorder, post-traumatic stress disorder or PTSD, acute stress disorder, and adjustment disorders. The DSM-5 notes the close relationship between these disorder diagnoses and anxiety disorders, obsessive-compulsive disorders, and dissociative disorders. You will most likely recognize PTSD as a disorder that has been diagnosed for years. However, some of these disorders are new and have now appeared in the DSM-5 for the first time. I cannot wait for you to view this lesson. Let's move on with the current lesson and discuss schizophreniform disorder. Schizophreniform disorder presents in the same way as schizophrenia, but it lasts less than 6 months. These patients also suffer from the positive and negative symptoms of schizophrenia, but somehow many of them recover and never develop schizophrenia. A diagnosis of schizophreniform disorder puts one at a greater risk for the development and eventual diagnosis of schizophrenia. Please note that the characteristic symptoms of schizophreniform disorder are the same as they are for schizophrenia. However, the difference lies in the duration of the disorder. The DSM-5 lists 4 criteria in addition to specifies for the diagnosis of schizophreniform disorder. Criterion A for schizophreniform disorder specifies that 2 or more of the following each present for a significant portion of time during 1 month or less if successfully treated. At least one of these symptoms must be 1, 2, or 3. These include the following: delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms such as diminished emotional expression or avolition. Criterion B states that an episode of the disorder lasts at least 1 month but less than 6 months. When the diagnosis must be made without waiting for recovery, it should be qualified as provisional. Criterion C for schizophreniform disorder states that schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out. The final criterion, criterion D, states that the disturbance is not attributable to the physiological effects of a substance, such as a drug of abuse or a medication, or another medical condition. The development and course of schizophreniform disorder are similar to that of schizophrenia. Approximately 1/3 of individuals with an initial diagnosis of schizophreniform disorder recover within 6 months, and schizophreniform disorder is their final diagnosis. Evidence suggests that the remaining 2/3 of individuals will eventually receive a diagnosis of schizophrenia or schizoaffective disorder. Let us look at the treatment for schizophreniform disorder. Schizophreniform disorder is treated in the same way as schizophrenia, with antipsychotic medications and psychotherapy. Oftentimes, such as with schizophrenia, patients may have a comorbid disorder such as depression, and such a diagnosis will be treated with antidepressant medications and/or a mood-stabilizing agent. Students, to date there is no real evidence for how schizophreniform disorder, a disorder that presents in the same ways as schizophrenia, does not continue to develop into schizophrenia. As you've learned, 1/3 of patients with this disorder do recover, and that is very positive. However, some do develop full-blown schizophrenia at a later stage. Let us move on to finish our lesson with schizoaffective disorder. Schizoaffective disorder, also classified under the psychotic disorders, is a disorder with a combination of symptoms of schizophrenia and mood disorders, such as depression and/or bipolar disorder. The DSM-5 most likely categorized it under psychotic disorders because of the prominent psychotic symptoms that patients experience when they have this disorder. There are 2 types of schizoaffective disorders, namely the bipolar type, which includes episodes of mania and sometimes depression, and the depressive type, which only includes major depressive episodes. Signs and symptoms of schizoaffective disorder depend on the type, such as bipolar type or depressive type, and may include some of the following symptoms: delusions, hallucinations, impaired communication and speech, such as incoherent speech, bizarre, unusual, or odd behavior, symptoms of depression, periods or episodes of mania, impaired occupational, academic, and social functioning, and problems with personal care, including hygiene and physical appearance. The DSM-5 lists 4 criteria for the diagnosis of schizoaffective disorder. Criterion A states that an uninterrupted period of illness during which there is a mood episode, such as a major depressive or manic episode, concurrent with criterion A of schizophrenia, must be present. Note that the major depressive episode must include criterion A1 for major depressive disorder, which is depressed mood. Criterion B states that delusions or hallucinations for 2 or more weeks in the absence of a major mood episode, such as a depressive or a manic episode, during the lifetime duration of the illness must have been present. Criterion C of the DSM-5 for schizoaffective disorder states that symptoms that meet the criteria for a major mood episode are present for the majority of the total duration of the active and residual portions of the illness. And finally, criterion D of the DSM-5 notes that the disturbance is not attributable to the effects of a substance, such as a drug of abuse, a medication, or another medical condition. Schizoaffective disorder is relatively rare. Its lifetime prevalence is approximately 0.3%, with males and females experiencing schizoaffective disorder at the same rate. However, males present with the disorder at an earlier age. The exact causes for why and how a person develops schizoaffective disorder are unknown, but the literature reveals that a combination of causes may contribute to the development of the disorder, including genetics. Schizoaffective disorder has been seen to run in families. However, not all relatives of patients with this disorder develop the disorder. When one has a relative with this disorder, it just increases the chance of also developing the disorder, indicating a variation in genes for each person, even though genes are implicated here. Brain chemistry and structure. Scientists believe that patients with this disorder may display differences in their brain structure and chemistry, but further research is being carried out to comprehensively explain the differences between the brains of schizoaffective patients and those with normal brain functions. In terms of brain chemicals, levels of serotonin, dopamine, and norepinephrine are implicated. Stress. Stressful life events may trigger the onset of the disorder. However, it may also indicate a genetic predisposition for having developed the disorder after a stressful life event has presented. Drug abuse. Psychoactive drugs, specifically LSD, have been linked to negatively affect the brain and to lead to the development of schizoaffective disorder. Let us look at the diagnostic concerns. Diagnosing a person with schizoaffective disorder is often complex or difficult, as they may present with only symptoms of a mood disorder or psychotic symptoms. For a diagnosis of schizoaffective disorder to be made correctly, the person must display the following symptoms: a period during which there are symptoms of a mood episode, either depression or mania, occurring at the same time when symptoms of schizophrenia are present. Delusions or hallucinations for 2 or more weeks in the absence of a mood episode. Symptoms that meet the diagnosis for a mood episode are present for the majority of the total duration of the illness, and the symptoms must not be attributable to medication or a drug of abuse. Students, before we conclude our lesson with the treatment of schizoaffective disorder, I just want to tell you that I've included an example of a typical pattern for the diagnostic confirmation of schizoaffective disorder in your summary notes. I will also include a case study for you as extracted from the DSM-5 Clinical Case Note Manual. Let's move on with the treatment of schizoaffective disorder. Physicians or psychiatrists who treat schizoaffective disorder must consider treating psychotic and mood symptoms. Therefore, medicinal protocols usually include antipsychotic medications to treat delusions and hallucinations, as well as a mood stabilizer for the bipolar type and an antidepressant type of medication for the depressive type of schizoaffective disorder. The long-term treatment of schizoaffective disorder includes the use of antipsychotic medications together with psychotherapy, with the mood episodes being treated when necessary, or in some cases, chronically. Students, and here we are again. You've just completed Lesson 5 of Module 4 for your course diploma in psychology. I cannot wait to see you soon for Lesson 6, in which we will discuss trauma and stressor-related disorders.